Thank you for the opportunity to explain to you about some of the basic urology as part of the Erlanger Symposium. I'm Amar Singh. I'm the chair of Department of Urology, been in town for 15 years. Just a quick overview of who we are. We are a comprehensive service, fellowship trained subspecialties in all, which is unique to our practice. One of the largest experience, multiple clinical locations, and leading the country in many areas. And above all, we take pride in offering the latest technologies. And the reason I'm telling you this is because our team is what we are proud of, and that's why we are here. So, why urology in primary care? It's an aging population that we are taking care of, where urological diseases, including cancers, can make up a majority of the impact on the quality of life. And what we will aim to do here today is cover a little bit about lower urinary tract symptoms, which I will interchangeably use as LUTS, or also bladder outlet obstruction. And we'll talk about assessment and treatment and what are some of the latest options for our patients. Secondly, we'll talk a little bit about the evaluation of renal masses and what are some of the latest treatment options. And lastly, hematuria workup and differential, which is very commonly seen in primary care setting. So let's talk a little bit about LUTS. It's lower urinary tract symptoms classically defined by frequency, urgency, and nocturia. This is something that I urge all of you to ask your patients about because it has not only impact on quality of life, but also on renal function. Hesitancy, weak and interrupted flow of urine, incomplete bladder emptying, and post micturition or post urination dribbling or incontinence. They all can be LUTS symptoms. So a little bit of basis of LUTS. This kind of shows you the bladder and prostate and outlet. Urethra goes through it, and the sphincter is intact. So as over times when prostate gets enlarged, all these symptoms develop. So what can we do for them? Basic things like general medical history, physical exam, urinary test, frequency volume chart. These are some of the things we do in office. Some of the lifestyle advices as far as avoiding certain foods and fluids. And always a good idea to check kidney function on these patients because significant portion of patients with end-stage renal disease have a background LUTS or bladder outlet obstruction that can make these symptoms worse. Some of these questionnaires, IPSS, can be helpful, and we do recommend getting a PSA in case the outlet in men, especially, is from prostate cancer. Medical management, and we are happy to always see these patients to assess these symptoms and further treat them. So BPH overview, quick. This is basically the microscopic description of a prostate. It's a glandular tissue, smooth muscle and connective tissues are in it. 60% of men by age 60 will have some aspect of enlargement, 80% by age 80. However, they all don't need to be treated unless it's a symptom, and it's purely a symptom. And the secondary side effect of it is the renal function issue. So current state of surgical therapy, and all of you are aware of medical therapy, so I'm not going to belabor that. However, in surgical therapy, I always say if only tool you have is a hammer, everything looks like a nail to you. And in LUTS, we actually have a variety of options available, and they're all provided to our patients at our institution. And we have extensive experience in all modalities over several years with good outcomes data. So which BPH surgery is most appealing? Well, there are many, and the list is quite long. However, I will talk about mainly the TURP, aquablation, some laser enucleation, and some of the minimally invasive options, and I'll show you some data and outcomes on them or recommendations as far as what the evidence suggests. So surgical indications, if somebody wants to not be on a pill, you have often we see someone 51-year-old healthy and who has bladder outlet obstruction but doesn't take any medication. There are minimally invasive options for them where you can treat them 15-minute procedures and they will come off the pill. Failure of medical therapy. Up to 40% of patients will not respond to alpha blockers and such. Renal insufficiency, which we talked about briefly. Urinary retention. When urinary retention is present, chances of medical management is almost minimal in its success. Recurrent urinary tract infections, bladder stones, and ultimately gross hematuria. So evaluation, we generally recommend some sort of imaging, whether it's ultrasound, MRI, and a scope is also done to ensure that you don't have some of the irritative voiding symptoms from some things like bladder cancer or bladder stone. And above all, commonly, it's not, uh, uh, we see it all the time where people say, oh, I did a DRE, it's enlarged. Well, DRE's effectiveness in estimating size is dismal. It's about 20%, if that. So ultimately, imaging is helpful. And again, if any one of you are interested, you can go look it up on AUA guidelines. This basically is a schematic that we use in our practice to guide us as far as treatments, and it's a good review. So if you go to auanet.org, you can see the charts and recommendations. So as far as treatments are concerned, not all prostates in all sizes cause symptoms, and size always doesn't have to do with symptoms. So sometimes it's the small prostate with high muscle tone that will cause obstruction, and some people have very large prostates where they have no symptoms. So when we tailor the treatment, whether it's TERP, aquablation, enucleations, urolift, whatever it is, it has to be tailored to the size of the prostate. So let's talk a little bit about microwave, which was in practice many years ago, and I'm putting this on just for completeness because it's fallen out of favor. In our practice, we do not even offer these because the retreatment rates were almost 70% at 3 to 4 years. And I'm of the school that when you take an elderly patient or generally elderly patient and you put them through a treatment, you better have longevity in that treatment. And so it's not practiced much. Needle ablation, same thing. It was in vogue quite earlier because of the reimbursements and other things. However, the data never panned out, so most people have stopped doing them. Urethral lift, this has been a great breakthrough in bladder outlet obstruction. It's a great option for men with somewhat a smaller to not very large prostate. And basically, it's an internal suture that's placed in the prostate, as illustrated by this schematic, where we go in with a scope and it keeps the prostatic urethra open. And so far, it has had very good outcome, up to 5 years data, and it has minimal effect on erectile dysfunction or ejaculation. Water vapor, or also known as resume. Here, the idea is you put high pressure steam in the prostate, and again, same thing, it erodes over time. The difference between this and urolift is this takes a while to kick in and has a little bit higher failure rate. Urolift, the relief are almost immediate. TERP, or transurethral resection of prostate, very often known by patients as Roto-Rooter. It basically says that you go in with a scope and you scrape the obstructive tissue. Now with the bipolar TERP, which we offer here, you use saline. So the classic TUR syndromes that we used to see, meaning hyponatremia, bleeding, and catheterization time, they've all been reduced significantly with bipolar TERP. So it can be done, and can be done safely. And so far, the data is very strong, and it's the gold standard treatment. Furthermore, you have photo lasers have come in now. This advantage of lasers are that it allows you to treat patients even when they're on somewhat of an anticoagulation. And lately, we have almost every man who is 60 years old is on some sort of anticoagulation, whether it's aspirin, Plavix, any of the newer antiplatelet therapy, or warfarin. So this is a great breakthrough in allowing us to treat these patients who are older, much larger prostates, and and at high risk for bleeding. And fortunately, we've been doing these here for almost 15 years and have one of the largest experiences in all of the United States. Aquablation is a technology that's coming slowly. We are evaluating it right now. This is a computer model where basically with ultrasound, you map out the prostate, and it's a high pressure water jet that ablates it. And then you have to go ahead and get hemostasis. However, the biggest challenge right now is that long-term complication and outcomes data is not available. And we'll see how it comes into play over the next several years. As you can see, this was just approved in 2019, so not a whole lot of time to evaluate this. And laser enucleation, as I talked about, the advantage here is basically go in with a laser and take out the entire adenoma. And this way you get pathology and has one of the longest long-term success rate. Simple prostatectomy, we don't do these that often anymore because of the alternatives. However, I'm putting this here for completeness. We can do these with a robot. We can do these open. Outcomes are good. It's just a little bit more invasive option. So in summary, if you look at the evidence level support, still TURP, laser vaporization, enucleations have about an evidence support level of level B, which is moderately strong evidence, and the rest of the others kind of fall out here. So most of us, we tend to focus our treatments on these, which includes things like UroLift, enucleations, and bipolar TURPs. And these therapies have yielded good outcomes with minimal complications and long-term success rate. And that's the biggest thing we look for in this patient population as we treat them, that long-term we should have a reasonable outcome. Now I'm going to switch gears and look at it to kidney masses, which I mentioned, because incidentally, all of you see patients who have had numerous scans, whether it's for gallbladder to bellyache to back pain, and they show up with kidney masses. And I wanted to take a minute to kind of talk about why are we interested in kidney masses. Well, kidney cancer is an indirect presentation of kidney masses. It's the 7th most common cancer in men, 10th common cause of cancer death. It used to be uncommon less than 45 years old. However, with obesity, cigarette usage, it's increasing. 50% are diagnosed when they're organ confined, and still about 25% are locally advanced or metastatic at time of diagnosis. And incidence is increasing. Some of us think it's because more and more people are being scanned. However, you can see the incidence is increasing across all demographics. However, the time at diagnosis or the size at time of diagnosis is slowly going down, which brings me to the next point, that because of this, most patients are presenting with smaller renal masses, and we can manage them in a different way than we classically did 20 years ago. So just a quick anatomy, you can have masses in kidney from either the meat of the kidney, in that case it's renal cell carcinoma, or it can be from the lining of the kidney or urothelium. In that case, it's urothelial carcinoma, and they tend to be more aggressive and act more like bladder cancer. Just to give you an example, this is a person with a CTU, and you can see this is normal collecting system on the left side, how smooth contour. Here there is mass here. This is coming from central area, so this is more than likely to be a urothelial carcinoma, and this was a patient of mine with urothelial carcinoma. Here again, one of the things we always ask for when we evaluate renal mass is contrast is your friend. So here you can see on a non-contrast imaging, this is a very subtle finding. However, once you give contrast, that lights up like a Christmas tree, and you can see that that's a renal mass, that's a solid renal mass, and it was a renal cell carcinoma. This is a classic example of what angiomyolipoma looks like. So anytime on a cross-sectional imaging, CT, if we see any fat in a tumor, by definition, it's angiomyolipoma. They tend to be benign, and usually we don't intervene until they're about more than 5 centimeters. And again, post-contrast, you can see fat is usually black. We can measure Hounsfield units and look at them. And if they have any tumor that has fat in it, we don't operate on them until they are much larger or more than 5 centimeters. So oftentimes on reports, you may see these terms, and I wanted to put this here so you can get some insight into how that correlates. So on ultrasound CT scan, you will see this term written, which is called Bosniak renal cyst. And that's a way we classify renal masses, especially cystic masses, which are more common nowadays because of routine screening. And it helps us risk stratify in terms of patient counseling and their risk assessment in terms of risk of cancer. So Bosniak 1 renal masses are usually simple cyst. 2 will have some septation or calcifications in it. 2F gets to minimal thick wall. 3 is measurable enhancement on contrast imaging, and 4, it has soft tissue component. And why does this matter? So first, before we talk about that, let me show you what classically that looks like. So this is ultrasound. This is a Bosniak 1 cyst. Another cyst example. This is a Bosniak 3 because you can see there is septations inside this cyst. There's calcification. Same thing here, and there is some soft tissue component beginning to form in here. So that's a border of 3 and 4. This would be a 4 because it's mostly soft tissue in it. And at the same time, this one out here in the periphery is a Bosniak 1 cyst. So again, the reason this is important is because it associated with the risk of malignancy. So Bosniak 1, chances of cancer is essentially 0. We tend to leave them alone. 2, it's about, again, 0, we leave them alone. 2F is 5 to 20%, we watch them, or we offer in younger patients options for surgery. So if somebody's 70-year-old with 2F, I will usually always watch them. If somebody is 35 years old, do they really want to go through lifetime of surveillance, or you can pluck these out, takes about half an hour to an hour, one night in the hospital, and be done for it. So that's a discussion we have with the patients. Bosniak 3, risk of cancer is almost more than 50%. We almost always will recommend some sort of operation. And 4, risk of cancer is more than 90%, so they lead to surgery for sure. Clinical staging wise and survival, the reason we want to find these tumors early is because if you find them in early stage, you have phenomenal long-term survival. If you find them late, only 20% of them will be around long-term. And this number, hopefully with the newer drugs, will go up. Things like oral therapy for advanced kidney cancer. So management, again, active surveillance is an option, radical nephrectomy is an option, partial nephrectomy is an option, and you can always ablate them. Active surveillance is reasonable for a smaller renal masses and in older patients. Not every small mass needs treatment because they have lower rates of metastatic disease. And now we know that anything less than 2 centimeters in older patients, we tend to watch them. Nephron sparing surgery is in the main option. You can do it any way you want. It's applicable for solitary kidney, bilateral renal masses, anyone who has history of stone disease, pyelo, reflux, chronic diabetes, hypertension, which pretty much I think sums up majority of the population if you look at this right here. So it's the main thing we want to do. Why we like to save them? Because renal insufficiency is bad, dialysis is not benign, and definitely transplant. Good luck getting a kidney in a majority of patients because the wait times are so ridiculously long. If you have chronic kidney disease, risk of death is higher. So again, we try to save the kidney if possible. This is what our classic kidney cancer patients look like several years ago, where they would have bilateral masses, recurrent masses, so on and so forth. Now we have kind of changed the paradigm with minimal invasive surgery by using smaller holes, robotic surgery to get to that point. This is a patient of mine with a horseshoe kidney. Several years ago, he came back with one. This is one with bilateral kidneys. And I'm proud to say that we have taken out all of these masses and kept them off dialysis without taking out the whole kidney. So nephron sparing surgery in this case is a huge advantage. And you can see here, this side, the big tumor was gone. And then subsequently, I went after the other side. We have an excellent and probably one of the most comprehensive robotic program or minimal invasive program to help take care of these patients. The latest addition to our team is the SP system, which is right here. Unlike classical robots where 5 different incisions were made, with this one, we make one incision, which is about a centimeter, about 2 centimeters long. And we can feed everything through there, which has minimized morbidity. And so far, people are recovering a little bit faster. And here is this cartoon. Basically, you can see through one trocar, we feed in the camera, multiple arms come in, and basically we are able to do the entire operation. Can't be done without a team. This is a quick snapshot of our team that went ahead and got trained, was one of the, only the, like, I would say first of the 5 places in the entire world to go get trained, and came down and helps us do this. So I'll play a quick clip that just to give an insight of how this works. So here you will see going in through the robot. This is a video from a prostatectomy with the use of robot, but we do kidney operations, bladder removal, all of those through that. And here are the 3 arms and camera come in, and they kind of fan out like a snake from there. And subsequently, we are able to do pretty much everything we did before, except through one incision. And excuse me, you may see some blood and stuff because it's a surgical video. So hopefully no one is squeamish. If you are, probably good time to stop. Now, again, I'm going to switch gears. Next, talk a little bit about basic hematuria workup. So I call hematuria or microhematuria a great masquerader because it's one of the most common urological diagnoses. It can be so many things in so many cases, some severe and life-threatening and some essentially benign. However, the workup is very important, and we need to be careful about who we ignore and who we go after, because the downside of missing a hematuria is someone could be dead on you in a few years if they have advanced bladder cancer. So it makes up for 27% of all urological evaluations. Screening studies note that about 6.5% of healthy participants, healthy individuals will have about, hematuria. So we want to make sure we don't overdo it, but at the same time, I think it needs to be evaluated. Differential diagnosis, as I said earlier, is massive. It could be cancer, both kidneys, urothelium, or bladder cancer. Urethral cancer in women, I've seen hematuria present as rare things as lymphoma of the urethra. It can be kidney stones, infections, prostatic disease, stricture disease, trauma, medical renal disease, congenital, and idiopathic, where we don't know anything about. Risk of malignancy, it's about 10% incidence in upper tract cancers, 14% if someone has gross hematuria. And 3.1% of all microscopic hematuria will be cancer. And types of cancers vary: bladder, kidney, and upper tract, and very rarely prostate cancer. Current practices, less than 50% of patients with hematuria are referred for urological evaluation. And that number is only 28% in women, because when a guy pees a blood, it's always an emergency. When a woman pees blood, it's always UTI. So that has translated into higher stage at time of diagnosis for advanced bladder cancer, and a much higher rate of mortality, not incidence, but mortality in women with bladder cancer. Because most women with even gross hematuria are presumed to have UTI and not addressed sooner. Guys, when they have UTI, they almost immediately get referred and they get worked up. So in those with risk factors such as, smoking, family history of kidney cancers, other things, exposure to chemical dyes, high intake of burnt up or barbecued foods. Some people even say hair dye can have an impact on it. There's some data on it. And there are certain occupations like truck drivers who are at high risk for bladder cancer should be evaluated a little bit sooner. So what's the goal? The goal is to provide a more individualized approach. We tailor the intensity to evaluate to the patient. For example, if I see an 18, 20-year-old with hematuria, they may not necessarily get the same workup as I see a 70-year-old smoker. And the AUA guideline basically helps us guide how we approach this. So microhematuria is defined as more than 3 RBC per high power field on microscopic evaluation. It's not defined by dipstick alone. However, a positive dipstick should prompt you to work them up. Initial evaluation, the same evaluation should be performed on patients, irrespective of being on anticoagulation or antiplatelet therapy. And that's, again, common misconception out in primary care and some specialty settings that if someone is on blood thinners, they should be blood. Well, that's not quite true. Because in those patients, if they have something underlying that predisposes them to bleed more when they're on blood thinner, but not necessarily just because they're on blood thinner. Initial low risk with persistent hematuria and repeat testing are classified as an intermediate or high risk. And evaluation with cystoscopy should be done and upper tract should be imaged. Usually we prefer CT urography in our practice because non-contrast shows you benign things like kidney stone. Contrast shows you the nephrogenic phase, which is here at 100-second, will show you renal masses, and excretory phase will show you urothelial or any kind of obstructive disease. So that's a basic workup, which we highly recommend. So again, thank you for your attention, time, and this was a great opportunity to talk to you. And if you have any questions, I have put my email there and my cell phone, so please do not hesitate to contact me. Appreciate your attention, and thanks for the opportunity. Thank you again. I'll take any questions if you guys have them. One of the questions that popped up, it said, is there any indication for alpha blocker or tamsulosin for recurrent lower urinary tract symptoms after surgical treatment? And the answer is yes, because not all TURPs are the same, depending on the age of the patient or who has done them. They may not have gone aggressively after the tissue. And in that case, alpha blocker, at least postoperatively, is useful for a few months. If patients who have recurrent symptoms, you can again continue that till they fail therapy. And the common question I get along those lines is, what's the life of a surgical intervention? So if you look at the laser enucleation of prostate data, or if you look at classically done a thorough TURP, it's about 10 years, 7 to 10 years it should be. However, some men will have rapid regrowth. You can use finasteride in that setting to prevent recurrent symptoms or recurrent growth, so on and so forth. The other question is that any recommendations for pelvic floor therapy? Usually in men for bladder outlet obstructive symptoms or urinary tract symptoms, only time pelvic therapy can be helpful is if they have more irritative than obstructive symptoms. And the second aspect is after TURP or enucleation or even prostatectomy for cancer, especially after benign surgical treatments like enucleation or TURP, the incidence of incontinence or stress incontinence is in single-digit percent. Is 1 to 5%, depending on which series you look at. In those men, pelvic floor therapy can be very helpful. But otherwise, to treat basic normal outlet obstructive symptoms, pelvic floor therapy is not very helpful. Next question is that's coming from the audience. One says, what is the approximate rate of erectile dysfunction following the newer procedures for BPH? So most of the data on ED after BPH procedure was on TURP, where thermal energy was used. With laser and some of the newer modalities, the incidence of ED is almost non-existent, very low. They do all have though ejaculatory problems, meaning they'll have orgasm, but they'll have a dry orgasm, not much semen comes out.
But most men who are in this age group, that's how usually no consequence unless they want to conceive children. So that's a side effect that we make them aware of. However, practical and day-to-day life, it doesn't have a huge impact on their quality of life. But in terms of erectile dysfunction itself or inability to have an hard erection, the current treatments almost have no impact on that. Should Next question, should Bosniak 2F cyst always be referred to urology or monitored with imaging? That's something that I think you have to discuss with patients, and it also depends on age. For example, if somebody is 75, 70 years old with comorbidities and they have 2F, you may want to follow them. If somebody is 30 years old, that's a question that needs to be discussed, that would you rather undergo a 30-minute procedure where you can pluck those out, go home same day, or if not next day, or have serial imaging for the rest of your life, which may be 50 years. And the benefits of radiation, cost, life, worrisome following. So that's a tricky discussion, but that definitely needs to be had. And if the way I see it, if you as a primary care are comfortable doing it, you can have it. If not, we are happy to have that discussion. However, in older population, I think 2F primary care should be followed by them. And if there is interval increase in growth and so on and so forth, then it can be referred to us. Again, thank you. We are running out of time, so I will end right here.